All right, everyone. Welcome to the Community and Public Health Committee meeting. My name is Mark Morowitz, the Health Commission Secretary, and I will take roll. Commissioner Christian.
Present.
Commissioner Salgado.
Present.
And just noting, this is Commissioner Salgado's first meeting. Welcome to the Health Commission. There'll be a more formal welcome at the full commission meeting in a few hours. I will read the land acknowledgement. The San Francisco Health Commission acknowledges that we are on the unceded ancestral homeland of the Ramaytush Ohlone, who are the original inhabitants of the San Francisco Peninsula. As the indigenous stewards of this land, and in accordance with their traditions, the Ramaytush Ohlone have never ceded, lost, nor forgotten their responsibilities as the caretakers of this place, as well as for all peoples who reside in their traditional territory. As guests, we recognize that we benefit from living and working on their traditional homeland. We wish to pay our respects by acknowledging the ancestors, elders, and relatives of the Ramaytush Ohlone community, and by affirming their sovereign rights as First Peoples. We can move on to item 2, which is the approval of the June 18th, 2024 committee minutes.
Thank you. So we have before us the minutes from the June 18th meeting. Is there any comment on these minutes?
Everyone in the room is staff, and there's no one who has received a accommodation to provide remote public comment. So there's no public comment on this item.
Any commissioner comments? And I have no comments. And so we need a motion to approve the minutes.
I so motion.
Second.
All those in favor?
Aye.
Thank you so much. The minutes are approved. We can move on, but we're going to switch the order of the items for those who are watching. We'll start with the HIV Health Services update. And let me pull up the presentation. Yes, and just speak regularly. The black bar is the microphone. Just watch the pages when you turn, please, so that you're not turning the page in the microphone. And ready to go.
Welcome.
Welcome, Delgado. Welcome to your new position. So I'm going to share with you a little bit about HIV Health Services. We are a section of ambulatory care within the San Francisco Health Network. And on that first slide there, you can see that's 25 Van Ness. We are privileged to live in or work in the 25 Van Ness building, beautiful Beaux Arts building. Come up and visit us on the 8th floor if you ever want to see our group. Next slide, please. So this is our vision and mission. I won't read it right at you, but I'll just kind of call out some of the main words. Our primary function is to oversee, and the state-of-the-art part is important because we really do look to make sure the system is as best it can be, and that we work to kind of both sustain it and to improve it all the time. And our goal, of course, is the health and well-being of people living with HIV. So that's what our unit functions on. A lot of our work is collaborative, both local, state, and federal partners. And we do a lot of work on promoting health equity so that everyone has equal outcomes with regard to HIV disease and control of the disease. And we really are working to make a system that is both comprehensive and sustainable. Next slide, please. This is kind of our mighty staff of 10, including me. So you can see there my colleagues or staff I'm proud of each and every one of them. They do a great job, and without them, I wouldn't be here presenting to you successfully as we hopefully you'll find that we are. Next slide. So if you could think about reading this next slide kind of as a clock and kind of starting with like 3-ish. So if you look at 3 o'clock, that's our total dollar amount. If you look below it, you can see the percentages, the divisions of the different fundings by classes, the 37, the 46, and the 60. And then if you go back to the pie chart there and look to the left, you can see the different funding sources. So we are majority general fund at this point, local. And Ryan White consists of 5 parts, and you can see the breakdown of the parts there. Including San Francisco's Getting to Zero, which is a subdivision of the general fund, as well as Ending the HIV Epidemic, which are additional funds that are kind of go through the Part A. We actually get every part now except for Part D, which is specific to women and children, and those go to those go to UCSF. As well as Part F, which is both dental schools as well as special projects, which we aren't doing at this point, but we have in the past. So finally, I'll direct you to the left-hand side of the slide, and that shows, unfortunately, that is a slide. It shows kind of 25 years of HIV funding from Ryan White Part A, and you can see it's been a steady decline. The reason for that is because it's been flat funded for a super long time, and so the pie gets divided among more parts. So as more jurisdictions, particularly in the southeast part of the US, have higher numbers of cases, they qualify, and now almost all of it is formula-based, but it's been increasingly formula-based, so the same dollars get shifted to our colleagues in the southeast. Okay, next slide. I'm assuming you guys would like me to go through the slides and then questions at the end. Is that okay? Great. So the next slide at the top, you can see the number of people who have touched a service that is funded through DPH HIV Health Services. And that 5,600 number is about 40% of people living with HIV in San Francisco. So we have a little over 12,000 people living with HIV in San Francisco. And a bit later, I'll compare and contrast how our population compares to the overall population of San Francisco. At the bottom of the chart, you see the two kind of columns of services. These are actually federal categories of service. The idea with the Ryan White program's funding is that it's comprehensive, so it's medical and everything that wraps around to kind of keep people glued in, supported, and as well, doing as well as they can. So on the left-hand side, you'll see those which are considered core services, and those are meant to, well, they've been adjusted to kind of match what would be happen through Medicaid or in our state Medi-Cal, and they're considered core required services. And then the second in blue is the support services. So this is 18 of the 23 allowable categories. We have a couple more we fund in small amounts, but that's the majority of the different kinds of services we fund. Next slide, please. So you may recall at the beginning, I kind of talked a lot about how we do a lot of collaboration. So this kind of evidences that. So we run over 65 contracts and MOUs for over 79 programs with 42 different partners, whether that be community-based organizations, UCSF, or sister programs within DPH. We have 40 contracts with those, with 58 separate programs and 26 not-for-profit community-based organizations. And I mean, over there on your right, we lifted a lot of the logos, so you can kind of see the range of the folks we work with. We also have 10 contracts for 12 different programs with 5 different divisions of UCSF. And we have 15 MOU supporting 18 programs with 11 different units within SFDPH. Next slide, please. So I think, Mark, if you hit this a second time, oh, there it is. Okay, so what you have here is all of our community partners. And then overlaid there with the kind of the lovely kind of light brown to dark brown shows people living with HIV by the density. So the richer the cafe au lait color there, the higher percentage of people living with HIV. So hopefully this is showing you that that the services are concentrated where people are living with HIV, or if not that, are our main transportation lines. Just a couple notes, a couple of those programs are street-based, in which case you see the kind of the mothership is the one that's in the diagram there. Next slide, please. So there's a little bit of look of the demographics. And so just kind of a little bit, we looked at age, gender, and race, ethnicity. Just to note, in the green column, it's San Francisco as a whole. And then in the blue column is, again, those that receive a service that originally is funded by HIV Health Services. And what you can see is that our clients are statistically more likely to be women, whether that's cis or trans, and identify as people of color. So the first box on your left is age, and then on your right is both gender and race ethnicity. And this data is pulled from the EPI report that SFDPH produces as well. Okay, next slide, please. We wanted to give kind of a particular call out to something that's very much emerging both nationally and locally, and that is the aging of the HIV population. And you may have started to hear stuff about long-term survivors and stuff. And I'm going to refer to it as HIV and aging, recognizing it's important for folks to be able to self-identify, but we also have a number of people who are, there are over 100 people that are less than 45 years old that have been living with HIV for 20 or more years. And we have a similar number of people that are over 60 who have been living with HIV for 10 years or less. So I'm going to refer to that as HIV and aging, but just to acknowledge that that's kind of an emerging and important self-identification for a number of people who are both elder and living with HIV. And I think that the key points on this slide, what it is here is we looked historically at the breakdown by ages, and then we projected it forward. So what we kind of did was did a snapshot of the current, and then we projected it forward. So this, I think, is a good snapshot, but it doesn't have the kind of modeling of who's leaving the system, whether because they move out or because of death or coming into the system because they're new. We think this is still really good because those numbers are pretty small. So the overall trend is probably pretty accurate. So just if you draw your attention to the right-hand side, kind of how the red and the purple boxes are increasing there. And so that by 2030, over half the population is going to living with HIV that we provide services are going to be over 60, and almost 20% are going to be over 70. And so that's coming to us in the next 5 years. Okay, on to the next slide. So I'm jumping around all over because I was instructed to be briefer. So if stuff isn't kind of following and you guys have a question, let me know. So I am going to shift it now to initial set of funding, which was proposed. It was a proposal under Trump to end the HIV epidemic. It was called EHE. And so it was another pot of money that was supposed to wrap around. And the goal you can see on the left was in the first 5 years, and we are now in year 5, was to reduce HIV infections by 75%, and then with the goal of going to 90%, decreasing new infections. And this is a national goal. And so the first year you can see it was 291 million that was allocated over, I think, 22 different Ryan White Part H jurisdictions. And then within the 291, 70 million was for care. So you may have had colleagues over from CHEP who also have received ending the HIV epidemic. They call it ending the epidemic because they have a more syndemic approach, multiple diseases, but we coordinate those funds together. Next slide, please. So I won't go into it, but there's basically 4 categories on the bottom left there of how they wanted us to look at the funding. And then on the right is kind of a happier picture. It shows how the funding has increased over the last 5 years. We are at year 5. And so they're at the point again at a federal level of appropriations. And I think you all know that really the federal, both the presidential and the Senate and the Congress is so much up in the air that this could be a very different story next year. But currently as we stand, it looks like for what I'm seeing, the appropriations on the House side is a decrease and also putting the prevention funds at risk for EHE, but the Senate, which is democratically controlled, has not yet weighed in. So I think there's a lot more to come, but I know you guys are interested in hearing the kind of the future picture, and I could say it's blurry at best. Best case scenario is we continue to grow. Worst case, we may be looking at terrible cuts. Next slide, please. So the goal of the EHE funding was to really attain equity, to really work with communities or populations that were not getting to the same level of viral suppression, that being taking medications and the medications were working at suppressing the virus in their body. So that we really looked at the data to see where do we want to focus on this. The populations that emerged were trans women, particularly with an emphasis on trans women of color, people experiencing homelessness or housing instability, and people that had a recent history of incarceration or folks that were justice involved, and then people with high risk substance use. And that's a use of substances which were making folks hard for people to keep a roof over their head, have good nutrition, take their medications. So not everyone who uses substances, but particularly that group. And so we're really driving towards getting people virally suppressed. So that's what we looked at. Now, of course, any person could be in multiple of these groups or just one. And just wanted to give a little bit of a sense of who it is. If you do a 10-year look back, 2010 to 2020, just give a sense of the numbers. So 126 were trans women, 409 were marginally housed or homeless, 236 were people who inject drugs that were diagnosed, and then 1,445 were folks with recent incarceration services that received services in jail from a program that was funded by HHS. So again, that's a little bit old. It's a 4-year look back. I also just want to be clear, there are plenty of trans women that are very successful in their lives and are positive and all of that. And there are other groups that are not doing well. But this was our attempt to close that gap looking at viral suppression. Next slide, please. So switching gears again, and this has to do with the way the federal funding worked. Baked into the legislation when it was originally funded was the idea that it was a community process that drove how services were designed and delivered. And so they configured the United States looking at incidence and prevalence for what they call eligible metropolitan areas, which could be anything from a single city like LA or New York to even kind of a few multi-state and counties clubbed together, which is how they came up. I think there are slightly over 50 eligible metropolitan areas as well as transitional areas, and councils consisting of consumers, people living with HIV, people from departments of public health, as well as service providers would get together, and they would kind of analyze the system each year and then prioritize and allocate the dollars. So what you saw in the beginning, that table with the core services and the wraparound services, that's what they prioritize. So they don't get into particular contracts, but they say, want to spend this much money on medical care, primary care, this much money on mental health. And then we take that and we put that into contracts. So our area is actually, our EMA is actually 3 counties along the coast. You can see that on the map on the right. San Francisco is slightly less than 88% of the population that's living with HIV, and we get the same amount of funding. And we're actually the grantee for the other 2 counties as well, but you could think of it as a pass-through. They have their own mechanisms and planning councils as well. Next slide, please. Shifting gears now to talk a little bit about our CQI work. So we have forever and ever, looked at CQI, quality improvement, with the idea of getting people into the cascade of care. That means knowing that they're positive, connecting them to care, making sure they get medications, and making sure they're virally suppressed, the virus is not detectable in their bloodstream. And then recently, about 4 or 5 years ago, we expanded on, and the first population that we wanted to look at was the disparity in Black African-American populations. And we had a goal to bring it up so that there was no disparity between all people living with HIV in our system of care and African Americans. And then we were able to, if you look at a 10-year thing, we've kind of steadily brought it up. We eliminated it for the last 2 years. It's popped up a tiny bit. I don't know if it would be like statistically significant, but it's something that we keep on working on to make sure it doesn't widen again. And then a couple of 3 years ago, we started looking at people experiencing housing instability or homelessness, which is a daunting task even from just figuring that out. But we're moving forward, and thanks to Epic, the new electronic medical record, we just be able to get more granular data. So again, the same thing was to increase from 7 to increase so that there was no kind of disparity. And so that's 74% is where we're started at, trying to get it to that same 87, and then from there even higher if we can. So we're trying to move the needle. To be honest, we're in very, very beginning stages of that. One is just getting good data, trying to sort out the different systems. But we do work with there's over 30 people who come to the meeting representing probably 12 different clinics in DPH, as well as a number of community partners. And so we provide the data down to kind of a patient list and then ask people to work those lists over. And we also provide an actual number of patients if they were able to, if your clinic is able to get another 12 or 14 or 16 people experiencing housing instability virally suppressed, then you statistically will eliminate that difference. So we try and give people actionable stuff as kind of the responsibility we've taken on so that we really can kind of make the system kind of successful for all. Next slide. I was asked to talk a little bit about the housing picture. I feel bad doing this to you right after the current cycle that we are locally with the funding, but here it is. So Ryan White Part A, we've already discussed about the last 20 years of flat funding and what that's meant for San Francisco. Ryan White Part B funding, we actually are fortunate in one sense. Part B funding is block granted to the states, and the vast majority of it pays for ADAP, AIDS Drug Assistance Program. So that's all the medications for people that are uninsured or underinsured get. And then they pass some money out directly to kind of counties with high incidence and prevalence of HIV. As you know, the state budget is not great either, and they're also trying to expand the Medi-Cal program to, well, they have already, to eliminate U.S. citizenship as a requirement. So I think that puts into jeopardy just some of this funding that may be eaten up just trying to meet other things. Part C funding, there has been what they, again, work with formulas that look at prevalence as well as incidence. So the total number of people living, and then as well as the number of new people getting infected each year. And for San Francisco, because we do have pretty comprehensive prevention, our incidences keeps dropping, whereas other places haven't had the resources to be that successful. So the pie shifts, and so our pie is a little smaller. So we were told that our ceiling amount is about 5% less than it can be. So you see that 287,480. So it will be a small decrease there. And then finally for the EHE, I discussed that a little bit earlier. We're at the end of this year will be the next 5 years will be appropriated, and the Freedom Caucus is wanting to cut this completely. So, and then of course on the Senate side, they're wanting to increase it. So maybe visiting you here soon, hopefully happily, and the next time we talk to say that there has been more money secured. You guys are probably aware that Mayor London Breed has committed to backfilling the Ryan White cuts, particularly for Part A. For San Francisco, that unfortunately doesn't cover our sister counties in the north and the south, but for us, that part will be covered. And you all may be aware that there is a community group, fairly large, fairly active, called HAPN, HIV/AIDS Providers Network, and they do a lot of lobbying with the Board of Supervisors as well as the mayors to restore federal funding backups. Next slide, please. Am I doing okay for time, or should I speed up? Okay, we're getting near the end. Thanks for hanging with me here. So this is kind of the challenges, and the first one is just all of the isms that we face, and I'm sure you guys on a monthly basis hear about racism, sexism, classism, so we face those challenges too. And I've talked a little bit at the next one is about HIV and aging, and I've kind of given you that detail. We are doing a lot of look to kind of partner with other programs, particularly DAS, as well as MOHCD, which has the HIV housing, to look at how we can expand and better integrate services. Housing shortage, I won't bend you.
Could you go back and explain the acronyms just for especially the new commission?
Sure. So MOHCD, Mayor's Office of Housing and Community Development, another city agency, and part of what they get is HOPWA, Housing Opportunities for People with AIDS. So that's again a federal program that's run through HUD, Housing and Urban Development, and then it's allocated also to the emergency metropolitan areas, the EMA. So that funding comes through to the city and county of San Francisco and goes to MOHCD. Did I get them all, Mark, or did I miss one? DAS. DAS is Disability and Aging Services, which is again a sister agency, HSA. And they specifically work with folks that are aging and or with disabilities. In fact, they just gave a training today for the HIV system of care, and we had like over 50 frontline providers there. So it was kind of exciting to see the interest to integrate those systems. So the next one is housing. Everyone kind of knows this housing situation, a tremendous problem, particularly for folks that are justice involved or substance use that just aren't able to even have a chance in the housing market. The next one about substance use and mental health. I'm sure you guys have heard plenty about that. And then the challenges about training and hiring and retention of staff. I think post-COVID, things seem to be rising and getting better for most areas. I think the real area of challenge is behavioral health services. And I think that's probably because, social worker folks, get bachelors and masters and then, did 2 years of kind of underpaid stuff while they get licensed, and, look around and see their colleagues that have bachelors making 20, 30,000 more. And, I think folks are starting to feel like the city gets super expensive. Part of what we've kind of done is acknowledge that we used to have like what I would call HIV care warriors that kind of committed for 20, 30, 40 years, their whole careers to this. And I think there's a reality as HIV becomes a chronic disease for many, people still care and are social justice oriented, but maybe it's HIV for a couple, 3 years and let me go on and work in another area, which I think is a good thing. So we are trying to do a lot to support in terms of like trainings not to burn out and that kind of stuff, as well as just realizing we have to kind of keep reorienting the system every couple of years. So we're doing more boot camp, that kind of stuff, and a little bit of joy in practice. So we're trying to, and we're also trying to right side the budget stuff as much as we can. But as you can see, without a growing budget, it's hard to put in raises. So we are looking at ways that we can kind of make it feel welcoming to our frontline folks, because they're the people that make it happen. I'm just here kind of talking about their work. Okay, next slide, please. So these are kind of some of our successes, mostly through EHE. The groups that I've mentioned we've been working on. We're also doing a lot with rolling out long-acting injectables for treatment. So those are medications that you do a loading dose and then you come in for an injection every 2 months. And it's looking very promising. Recent studies to go to every 4 months, and then yet another study looking at every 6 months. So this could be a real game changer. So we're kind of really focused on how to kind of spread that throughout our DPH and sister systems, as well as seeing what works and what doesn't work so we can improve on it. We continue to work on our viral load suppression. I've already kind of mentioned those two areas. We have, with the EHE funding, we've also kind of expanded gender affirming services to trans folks. We've also tried what's called braided funding, looking at ways we can take the CDC HIV prevention funding and the HIV care funding through HRSA, HRSA, Human Resources Services Administration, have HIV AIDS Bureau that administer the Part A. To look if we can actually jointly fund mostly community-based, but also some DPH positions. So we can give what's called status neutral service. It doesn't matter if you're positive or negative or unknown, the same person can provide you that service. And I think we have, next slide, please. Again, this is my staff, and I know it's obnoxious, but I have the best staff on the entire planet, not only in DPH. Hopefully you can come meet them one day. And I will adjourn with that and see if anyone has any questions.
And there's no public comment, so it's just whatever you two feel like discussing.
Well, thank you for the presentation, and I'm actually sure that you do have the best staff because the whole system in San Francisco has the best staff available. And we see that pretty much at each commission meeting, the incredible work that people are doing, the difficult and hard work and the great dedication people have to it. So I appreciate you highlighting your staff and applaud you all with that. Thank you for this presentation. Just overall, would you, in a summary way, would you say that the rate of people contracting HIV is going down in addition to the number of people who are thankfully experiencing viral suppression going up, therefore together creating a decrease in the number of people who are, well, I guess people that have viral suppression are living with AIDS, but the number of people who are not being, not suffering.
Absolutely. So what I can say is, when they talk about the elimination of HIV, there's kind of two ways you can talk about it, right? There is nobody living at all with HIV. It's like completely eradicated, like the way we thought about polio. Or you can do models that say if your new infection rate is small enough and keeps declining, and people are surviving longer and longer and longer and not spreading HIV, that's another kind of functional way to look at ending the epidemic. And that's why you saw those numbers of 90% being virally suppressed and 95%. Because if we could get there eventually, this is kind of disease modeling, we would have no more HIV. People living with HIV would have as close to normal lives as possible and would not share their virus, or the people who are HIV negative would be being safe and careful at whether it's taking medications to prevent it or just good discussions and harm reduction stuff. So it definitely is moving that way, although you guys kind of know the nature of public health. Sometimes you can almost completely eradicate and something pops back. So, but the story in the whole is looking much better. And for people living with HIV, people now diagnosed now have close to normal lifespans if they have access to good care. What you tend to see is we call it considered a chronic disease, but because it's inflammatory, your body's kind of constantly at a low level fighting it off. So it just means you're more susceptible to chronic diseases of middle age and more advanced age. You tend to see a 2 to 5 or even a 7-year onset. So whether that's diabetes or, issues with blood pressure, all that stuff, it just tends to happen earlier for people with HIV because their immune systems are working harder to keep them safe. But yes, and I should just say my colleagues at CHEP work very, very hard from the HIV prevention side, and I think you'll probably have a conversation with them in the near future. We get them once they test positive.
Thank you. You show, I'm not sure the number of the slide, the HIV and aging slide, and the projection going out to 2030, indicating that younger people are going to the number of younger people who contract HIV is projected to continue to decrease?
Decrease, yes, and you can yes. So this is actually looking at the positive folks here. So that light green at the end is the number of young people. So that's kind of an indirect way of saying it's going to decrease. But, if you look we used to have about 1,000 people a year seroconverting, and we're now about 150. So we've had, a 90% decrease in new infections from the height of the epidemic. So that way we're doing a great job. There's still more to go. And, again, I'm speaking for my colleagues, particularly young MSM of color. The uptake of PrEP is still not equitative. Latinx men and young African-American men have less opportunities. And we see that just because there are fewer of them as a percentage of the total population compared to those on our. So it's definitely still more work to do, and on the whole, and that's true nationally as well, those two groups. But certainly within San Francisco, there's a lot of success.
And are you looking at PrEP? What are the primary modalities that are helping decrease?
Sure, I'm happy to talk about, I'm not the expert on that when I'm on the care side, but I can certainly give you some thoughts, and then you can hear from more of the
Thoughts
experts.
are great.
So, of course, there's the prevention and testing, and then the uptake of PrEP, pre-exposure prophylaxis. And so there's a daily pill. And then, as I mentioned, there's long-acting PrEP, which is an injection in the buttocks, which goes every 2 months. And certainly there's been huge PrEP uptake, and there is a lot of work to address those disparities, and also in the trans community to do extra work to make sure that folks, one, know about it, and two, understand it and have a chance to ask if it's the right thing for them, and then to get in and get the services. So those are the kind of the primary thing. The other thing is that, I don't know if you've heard of U equals U, which basically says undetectable, meaning we can't detect the virus in your bloodstream, means untransmissible. It means that you will not in your sexual fluids. We're not talking about blood for people that share equipment that inject, that share needles, that you can't transmit it to a person. So you can't acquire it from a person if you're negative and your partner is positive. If she or he is virologically suppressed or they are virologically suppressed, they can't pass it to you. And so as you see, we get these very high percentages of people that are virally suppressed, and whether people may be making different choices, which may be also use a barrier or not, but we know that because they're virally suppressed, that they're not going to transmit HIV. So the other way that we work on the prevention side is getting everyone who's HIV positive in care and virally suppressed, and that we've also had great success with.
Thank you. And can you just touch generally on the reasons that we find that women and people who identify as persons of color are most likely to be have in the HIV population?
In the care, meaning not having private insurance. So
yeah.
Personally, I would say it's racism and sexism and classism, and the fact that some of these women did get it directly from their own the stuff that they've done, but many of them it's because their partners were positive and didn't have the information or the power to negotiate different things. What I can say is that our system is designed with centers of excellence. So we have 2 programs that are focused on women, and their viral suppression is very, very high. No, they're also an aging population too, and we see what's predictive of higher viral suppression is the older you are. So there's very high levels of viral suppression in women. So because they on the whole are an older population in San Francisco, that wouldn't be true on the East Coast.
Thank you. Mr. Salgado, do you have any questions or anything you'd like to say?
Thank you. First of all, thank you for your presentation. I had mentioned to Mark, I love the presentation last night on both pamphlets because easy to read. I just have a quick question for you. In all of the information that you've given us, what percentage of the budget has been allocated for prevention?
So I can't quite speak to that because again, I'm on the care side. There is, but I'm sure my colleagues from CHEP can talk about it. I don't know the total budget number. I don't think. So I would.
I can follow up with that. It's another division because Bill only represents the people who are HIV positive. So it's on the people who have already tested positive.
Positive,
There's a whole
okay.
nother group that works with prevention, but I can follow up with that.
Got
And
it.
we do work very closely. I just don't know their budgets at that level. But yeah, we can get that information, sure.
Yeah, because the numbers seem low, so something's being done right, I think.
And it's different sources of funding because that comes from the Center for Disease Control because it's prevention, and this comes from the HH.
Have HIV
Yeah.
AIDS Bureau from HRSA.
Right.
So,
Sounds good.
yeah.
All right, thank you.
But they are facing the same challenges. You're going to hear very similar stuff about the decreasing funding scenario. In fact, they've been cut worse than we have. The CDC is kind of more vulnerable at a federal level to cuts. So that's also true for STIs, STDs as well.
Commissioner, may I ask one quick question? Could you explain a little bit about the issues that folks who were older with HIV are facing? Because I know a few years ago, there was kind of an uproar from that community, and the commissioners probably don't know, and because it's not just about aging, it's also about some social issues around loneliness and that kind of thing.
Sure, sure. So the great thing about long-term survivor is it's kind of a self-definition that's grown out of the community. The challenging part of it is that, of course, as I mentioned, there's lots of people living with HIV for their entire lives that are in their 20s, 30s, and 40s. And then there are people who are elders who only got HIV 5, 10, or even 2 years ago. But the majority has been folks that have been kind of over 60 and probably have been living with HIV for over 20 years. So, and many for 30 and 40. So I don't know if you guys are old enough to remember back to the 80s, but you know, people have lost 2/3 and 3/4 of their families of choice and their friends in their communities and struggled if they were going to survive this. And you know, many of their partners, husbands, and you know, loved ones and you know, families of choice did not. Then HIV, then you know, medications kind of became available and it became increasingly chronic. And so you know, people were out in the streets fighting to not, you know, to have food delivered, you know, to their rooms instead of left outside in the hospital. Just terrible stories, you know, which is probably true in any new epidemic, but certainly all the other stuff that were around social kind of stigma impacted. So this is a group of people that are survivors and knew that to raise their voices and be visible was the only way they were going to survive this when kind of an indifferent federal response. And then all of a sudden it became chronic and everyone survived and everyone was growing old. This group oftentimes were spent into, you know, poverty, or if not poverty, just depending on a social network. I mean, then it's just kind of a feeling everyone's moved on. Oh, HIV is chronic, and you know, and feeling like they're disappearing. And then of course you lose 3/4 of your community at 20 and 30. It's not as easy in your 40s and 50s and 60s to rebuild a community. So folks just are experiencing a lot of social isolation. And so, I mean, there's a lot of work that's been done. I could come back and share with you some of the stuff that both has grown out of the community and that also DPH has done to support. But there's kind of now a new resurgence. Hey, don't forget us. And then, you know, I mentioned those chronic conditions, but also some are progressive. And so you have kind of, I would say, some pent up activism that is kind of feeling of being forgotten again. So we tend to see people kind of saying, hey, I'm still here. I survived this. Don't forget us. We want to be. And then as you see, as the systems move a little more, we're trying to pull up people that have been homeless or may not be LGBT, and or trans women and or other communities where we see the disparities. And the pie is kind of shrinking or barely staying the same size. You kind of get that kind of competition stuff and feeling like, hey, you've forgotten us just because we survived doesn't mean we have great quality of life. And yes, we're biologically suppressed, but you know, we feel very much alone and under supported. So, you know, our work has kind of been to involve them and pull them in and also hear what they have to say.
Follow up to that, has that, I do remember the 80s, and has this activism become kind of consolidated? Is it, or are you seeing it individual basis, or are there groups being formed and?
Definitely groups being formed. San Francisco AIDS Foundation actually has a program kind of focus specifically on that group, and for that group and the voice. And then there's some national stuff that's happening, and some people that sit on our planning council. Remember, I talked about the planning council over the 3 groups. That voice is definitely there. And then they've done some actions here as well to the Department of Public Health, that kind of stuff. So, so yes, it's not a quiet group for sure. They're not afraid to speak their minds.
Great.
They've attended here at times to yell so that they get more attention and therefore more funding. And I think that was successful.
Thank you.
Sure. Thank you guys, and thank you for the work you all do. Appreciate it.
Thank you for your work.
All right, we can move on to the item 3, reserve for accelerated disease response. 3 presenters, and I will pull up the presentation. Please introduce yourselves.
Good afternoon. Thank you for the opportunity to present to you about the Reserve for Accelerated Disease Response, or RADAR. I'm Julia Jansen. I'm the medical director for RADAR, and I'll be presenting today alongside Joshua Cristantiello, the RADAR program manager, and Jennifer Banta, the RADAR trading coordinator. Next slide, please. This is an org chart of the Department of Public Health, and the RADAR team sits within the Disease Prevention and Control branch, outlined here in red. Our team collaborates with the Center for Learning and Innovation branch, the Applied Research Community Health Epidemiology and Surveillance branch, and the Public Health Preparedness and Response branch, outlined in blue. Next slide, please. Today, we'll be covering the role of the disease intervention specialist workforce, the need for strengthening this workforce, and the funding and RADAR mission and org charts. We'll highlight RADAR projects and end with where we are now. So let's go ahead and get started. Next slide, please. In the last 4 years, we've experienced 2 major outbreaks that have rapidly swept the globe: COVID and then Mpox. These took the national stage, highlighted in newspapers and TV worldwide. They were big outbreaks, and they required big responses. At the local level, disease intervention staff conduct case investigation and contact tracing and move to prevent and control disease. Their work is visible during those big outbreaks, but most days their work is invisible and unseen as they reach out to patients and compassionately conduct their work to protect and care for our local community. The staff that do this every day are a part of the disease intervention workforce. Next slide, please. So who are the disease intervention workforce and what do they do? Disease intervention specialists, or as I'll call them, DIS, are the frontline workers of this health workforce. They're sometimes referred to as case investigators, contact tracers, disease detectives, or first responders. During emerging or re-emerging infections, such as Mpox or COVID, they lead contact tracing efforts. During non-activation times, they respond to reportable infections by providing non-judgmental support to individuals, connecting people to testing, treatment, and referrals, and supporting notification of exposed individuals. At SFDPH, DIS includes 2587 Health Worker 3s, 2806 Disease Control Investigators, and 2830 nurses who are in the tuberculosis section, the communicable disease section, and the HIV and STI section. There are approximately 30 DIS positions at SFDPH. These staff come from the communities that we serve and often have lived experience. Much of the training for these positions are on the job and includes motivational interviewing, cultural competence, communication and conflict resolution, and racial humility and equity, in addition to the disease-specific knowledge. It can take 6 months or more for a new DIS to complete training. The important daily work that DIS do is unique to this workforce and is not duplicated by other entities within DPH. The full DIS workforce also includes supervisors and managers, as well as directors and epidemiologists who work to analyze and use data to protect our community. In San Francisco, these staff and the Disease Prevention and Control Branch respond to infectious disease threats first to determine what is happening locally, who is currently affected and who is at risk, and how we can prevent and control transmission. Next slide, please. In 2023, a study published in Health Affairs analyzed retention of the public health workforce at state and local health departments. The study found that nearly half of state and local public health employees left their organizations from 2017 to 2021, creating a critical lack of skills and experience across the nation. Among those who left, 77% had less than 5 years of work experience and 74% were under 35. This means that most departures from the workplace were not due to retirements. Among big cities in Region 9, which includes San Francisco, top reasons for leaving are listed on the side there and include work overload, burnout, lack of advancement opportunities, stress, and lack of support. We saw during the COVID-19 pandemic and during MPOX the essential need for a well-trained, supported, prepared, and experienced workforce who can rapidly respond. This was a call to action to invest in the DIS workforce. And luckily, funding allocated through the American Rescue Plan Act of 2021 gave us the resources to do just that. Next slide, please. In March of 2021, the American Rescue Plan Act was signed by Congress to provide financial relief from the economic effects of COVID-19. Congress included funding to strengthen the DIS workforce in this act, and CDC provided these funds to STI programs in health departments across the country. STI programs have been leaders in using DIS to prevent the spread of HIV and syphilis for decades. And during COVID, DIS from HIV and STI programs across the country stepped up to be leaders in the COVID case investigation and contact tracing workforce. This allocation of funding from Congress recognized the critical need to build out infrastructure to maintain a well-trained, robust, and thriving disease intervention workforce, and that can maintain public health daily and respond in times of emergency. San Francisco initially received $2.2 million a year for 5 years to support this work. I'm now going to hand off to Joshua Cristantiello, the Radar Program Manager, to tell you more about our program. Next slide, please.
Thank you, Julia. Good afternoon, Commissioners. I'm Joshua Cristantiello. We use the funding that Dr. Jansen just mentioned to create RADAR, which is the Reserve for Accelerated Disease Response. We're a new, small, versatile group that is housed within disease prevention and control. And we aim to strengthen our DIS programs, prepare these professionals for the new normal, and to keep them ready to respond to existing and unknown threats. 15 new positions were initially created, tailored to areas of opportunity that were identified by the workforce themselves during our work plan phase. These positions increased our DIS workforce by more than 20%. Some of these positions increased numbers of roles that already existed, but Radar did something unique as well. We added skill sets and tools to our workforce by creating unique positions that had not existed before, whose value lies in their ability to be flexible and to address gaps identified by the workforce as they arise. And I'll be talking about that more in the next slide. Radar helps to hire new positions. We help to train up new and existing staff. We help to streamline collaboration between teams by convening and facilitating work groups. And we provide quality assurance and evaluative support to disease intervention programs. Our mission, which we sometimes refer to as our pillars, is pictured on this slide. And at the base there, you can see what we consider to be two of our foundational values, that of evaluation and quality improvement and racial and health equity. And now I'd like to introduce you to a few of the people that do this work. Next slide, please. Here in green, you can see 8 of the 10 core Radar team positions that are currently filled. I won't have time to mention all of them, but I'd like to call your attention to Dr. Jansen, who you just heard from, who is our medical director and our link to the STI HIV section, as she also serves as medical director for the LINKS program. We also have Dr. Jennifer Banta, who you'll hear from next, who leads a small but mighty training team that has done everything from working to enhance our workforce's digital literacy all the way through to helping to improve outbreak response as we move forward. We also added a position to address a long-standing gap, which is that of the maintenance, modernization, and integration of our disease surveillance and database systems. And that communicable disease database manager is currently held by Nick Spar, as pictured there. Radar also created a dedicated epidemiologist 2 position, whose main area of work is to measure the impact of the work that the DIS do. The RADAR team provides support across all disease areas, that is tuberculosis, communicable disease, and STI and HIV. And I'd like to call your attention to one more key feature of our program design, and that is the first R in RADAR, the reserve. Anyone on the core team of RADAR is a reserve that can pivot to aid in emergent disease response. They can put their long-term projects aside and provide relief to the people doing the frontline work, even while emergency structures are still being put into place. Next slide, please. Here, I'll call your attention to format of this slide, which you'll see for the rest of the presentation. We'll be looking at opportunities for improvement that RADAR was asked to interact with, and also we'll be talking about our measures of success here. And Dr. Jennifer Banter will bring you through the rest, but I wanted to talk about one of these examples since it is a good example of the silo busting and cross-departmental work that RADAR does, and it's the creation of a community of practice. When doing interviews with the DIS workforce to find out where we needed to improve and what the gaps were, one of the resounding consensuses was that there needed to be more cross-unit collaboration and communication. And we decided to focus on a group of supervisors, the supervisors that supervise the frontline disease intervention specialists. We sought to see improvement here by convening a community of practice. A community of practice is a group of professionals that share an area of practice or interest, who meet regularly to share resources and talk about their experience. And so we had all of these DIS supervisors from tuberculosis, communicable disease, and the STI and HIV section suddenly having a place to meet to move their practice forward, which is namely charting the path of our DIS workforce into the future. Since then, we have hosted over 50 meetings since 2022 for those supervisors. And just 2 months ago, we started a new community of practice for the frontline disease intervention specialists themselves. With that, I'll turn it over to Dr. Banta to talk to you about some other achievements that we're proud of.
Thanks, Joshua. Good afternoon. Next slide, please. So the next opportunity I would like to talk about is something that we identified early on with the supervisors community of practice that Joshua just spoke about. And this was something we identified in that training, both during onboarding and for a refresher and cross training, was a gap across all areas of disease prevention. And while we all know that shadowing and on-the-job training can't be replaced, there was an opportunity to create engaging current content to be used for onboarding and refresher training for staff. The visual you see here with the mosquitoes is an introduction to vector-borne diseases in California and San Francisco. And it's one of about 8 core lessons we made available for the over 80 diseases. That's right, 80 diseases the communicable disease team responds to in the city. I was shocked to learn this number 80. That's a lot that people have to learn to train to and respond to when they come into work, 80 diseases. Anyone with an email can access these courses, so you are also invited to take a look via the email we sent out with our materials. We wanted to make sure our great content was accessible to as many people as possible. To date, our core communicable disease series has reached 112 unique users or learners across both Population Health Division or PHD and also a broader network of community-based organizations, students, and interns in San Francisco, which we're really proud of. So we wanted to get it out as broadly as possible and make it accessible. This course is an example of an onboarding content improvement, and we've also done a lot with onboarding process improvements by developing onboarding training manuals for disease prevention and control teams. And I'd like to tell you a little bit about what some of the staff had to say about using these tools on the next slide, please. On the right, you see quotes from colleagues who onboarded with our new manual, both supervisors and frontline staff. And I'll encourage you to read all of them, but I'm just going to read the second one for the sake of time. And the second one came from a supervisor in the links department. As a supervisor, I found the manual to be equally valuable. It enabled me to offer the same level of flexibility to the staff I brought on board, allowing them to learn and grow at their own pace. Now, we all know that learners do not learn at the same pace or in the same way. So offering this type of flexibility to learners is critical in setting them up for success from the beginning in their roles. We're really happy to hear about this feedback. And on the left, if we look at the opportunity to transform the workforce, what we think about transforming the workforce, we understand that the workforce, this DIS workforce, is part of our community too. And Radar, myself included, we're taking care of the people who take care of San Francisco, and we take that job really seriously. I was sitting here excited to talk about work because I actually love our work. This is not in my script. I'm just going to tell you, like, I actually love the work. Dr. Jansen spoke earlier about a call to action in response to the startling trends in the workforce during the pandemic in public health, but also across the nation. This is not just unique to public health. It's not unique to San Francisco. So on the left, you see some things that we are doing to transform the workforce ourselves at the local level. In summary, our work is reaching more people as our initiatives expand to reach more people. A couple of our initiatives have gone PhD-wide, which means broader than just disease prevention and control. And we're also working on actionable equity and digital literacy, which means for us that we make sure people that are hired into disease prevention and control teams can use their computers the way they need to from day one. So we'll assess where they are and then check what their needs are and make sure they can use all the software and applications and meet with them until they're competent in them. And that's different for every learner, but we do that one-on-one. And we also keep our workforce healthy well and working with data-informed intervention. Next slide, please. So as Joshua said, the first R in Radar stands for a reserve. And I was one of 2 Radar team members to be deployed during the MPOX response. And what that meant was I got to quickly work with the communicable disease section team, nurses, investigators, labs, and doctors prior to the activation of a formal incident command structure. And then through that transition, when it did sorry about that. We established standard works based on a COVID framework, and then also established other resources, which you can see here on this slide. And I also want to highlight a special cross-training opportunity that we took during MPOX that will really highlight what we're able to do when we work together and kind of de-silo like Joshua talked about. Next slide, please. So MPOX required nurses and case investigators typically working in other areas of communicable disease, those 80 I mentioned previously, to quickly get comfortable with detailed interviews on sexual behavior, which for some of them was new. Radar partnered with some of our best disease intervention specialists in sexual health to build a training for our communicable disease DIS to get comfortable with the language in the script and practice gathering the data that they needed in a complete way that our at-risk groups in the community would resonate with on calls. Because it was one thing to ask the questions, but it was another thing how they asked the questions was really important too, how they were asking the questions, not just the right questions, but how the questions were asked. As a result, the CD participants that were in the training, and you can see this on the graph, reported an increased level of skill and preparedness for conducting these culturally sensitive sexual and drug use health interviews. So we were really proud of this outcome, and that was before going in to conduct this. And we put this together really quickly. Next slide, please. And last, we've had a couple of opportunities to work on outbreak preparedness. And one way we do this is through outbreak simulation exercises. If that sounds like an exciting event, I can promise you they are. In 2022, we held 2 simulation exercises for staff. One was looking at a novel COVID-19 variant, and the other at a scenario involving antibiotic-resistant gonorrhea. In these exercises, we're able to look at our preparedness, response, and recovery prior to an actual emergency and test our plans. We identified areas of strengths and improvement. For COVID, we had participants from across SFDPH and local skilled nursing facilities, and they reported being better prepared for a future outbreak on the post-test. And when we worked with antibiotic-resistant gonorrhea, the results showed that the participants that we brought together reported not only being immediately more prepared for an actual event in the post-test, but they also continue to work together today to implement recommendations from the event. One of these, for example, is implementing treatment failure for clinicians. We've also started applying lessons learned from COVID and Mpox to better improve our responsiveness for future outbreaks. Thank you for letting me tell you a little bit about our work. And now I'll pass the floor back to Dr. Jansen. Next slide, please.
Thank you, Dr. Banta. So unfortunately, one threat to maintaining preparedness and continued investment in strengthening and preparing this workforce is the loss of funding for the RADAR team. In 2023, we heard that because our funding was bundled with the American Rescue Plan Act, the final 2 years of our funding was rescinded as a part of Biden's debt ceiling deal. The rescission of $400 million of funding allocated federally across the country for strengthening the DIS workforce included the funds for the RADAR team. We're currently able to sustain the team through February of 2026, the latest we can spend remaining funds, and have worked to move team members to other funding sources where possible. We're seeking other sources of funding, but with a tight fiscal environment, we're concerned many of the strides may be lost over time if this team is lost. Next slide, please. As we've discussed, the DIS workforce is the first line of public health response, and the RADAR team has stepped in to provide a needed and missing function. RADAR has stepped in to strengthen this workforce, filling in essential gaps that are challenging for staff to complete while also conducting their core duties. You heard today about our communities of practice that focus on professional development of staff while also leveraging peer-to-peer networks to facilitate communication and learning best practices. You also heard about RADAR's commitment to building sustainable, clear, and user-friendly training content to ensure rapid onboarding and mastery for new staff. RADAR has an ongoing mission to maintain preparedness of the DIS workforce for the next big outbreak. And when that bigger outbreak arrives, RADAR responds, such as how we stepped in to provide support both for infrastructure and for cross-training of the communicable disease staff in the sexual health interview when Mpox arrived in 2022. Just in the last 6 months, we've heard about H5N1 as a new potential threat. Ensuring that infrastructure is in place to support and maintain a thriving, well-trained, ready DIS workforce is critical to maintaining public health preparedness. In an increasingly interconnected world, with climate change at our doorstep, we know we must be ready. And the response, it starts at the local level. Next slide, please. Thank you so much for your time and for giving us the opportunity to share about our work and our team. I'll ask my colleagues to come join me up front now, and we welcome any questions.
And again, there's no public comment.
Thank you, Mark. Wow. Thank you for this presentation. And I just want to say how much I appreciate not only the work, but the enthusiasm that you all clearly have for it, and the love that you have for it and the energy. It's vibrating off of you. So I just want you to know that we see that as well. It's, fundamentally, everything that you've said is impressive, but what is also very impressive is that you are, as you've done this work and done the trainings and taken care of the people who take care of the city, you've created an infrastructure that, when we go through these periods of losing funding or people, that will be there for, modification, use and modification for whatever other disasters visit us. So thank you for that infrastructure that is sorely needed and will be clearly really useful. Commissioner Salgado, do you have anything to ask right now?
I have no questions, but thank you for the presentation.
So the community of practice is really something that seems fundamentally supportive of the ongoing work. The individuals who are doing the work and the individuals that come into it. Was there anything like this before you created it?
I can take that question. There was as needed communication before.
Mm.
So if there was a staff shortage in a outbreak that was overwhelming the resources in STI, they might arrange to have an informal activation, borrow staff, reallocate, et cetera. But no, there was no formal cadence to meet, to compare, to share resources, to plan for the possibility of sharing resources, or even just to have a space to step away from people's teams. And a lot of that is just because of the overwhelming amount of work. And I think in the beginning, when we got this group started, our group kind of half imposed and worked with the DIS supervisors a cadence, and it was weekly. But as we've been working with them to kind of hand over the reins of a group that truly does belong to them, we found a cadence that works a bit better with their resources, their timing, and we've seen buy-in and attendance just go sky high. And now we meet quarterly in person, and I think are having greater impact than when we had weekly remote.
With the funding question, do you, and maybe this is already happening, do you anticipate that you and people like you who have the functions that you have now will be created in different parts of the of DPH, or particularly in the disease response area, in case that your unique group is no longer funded and can't exist anymore?
Yeah, I can take that question. So I think one of the big differences between our group and some of those other groups, like the Center for Learning and Innovation and FEPR, who does emergency response, is breadth versus depth. So their centers are able to provide a lot more breadth, and our team provides a lot more depth and concentrated attention, time, training, and preparedness support for this particular workforce. So we hope that we would be able to move some of these pieces into those structures. But a lot of what we do is really unique and isn't being duplicated in other places. And those structures don't necessarily have the ability to absorb additional work on top of what they're currently doing. So what we're really trying to do now is try to find ways to be able to sustain this team and find ways to integrate the work into other work that's happening. But we are concerned that the infrastructure that we've created and the gains that have been made would be lost over time without this team.
Yeah, I can see that. And, you know, one of the many impressive things that you're doing is the digital literacy and making sure that people who work understand how to use their computers and the software. I mean, there's, you know, I'm a city worker, and the passing familiarity that I sometimes have with the software that we have. You kind of learn to use it in the basic things, but you know that there's so much more that could be done. And, you know, I'm sure I could be much more efficient if I knew how to better use some of the software. So that is really a great thing that you're doing, and, you know, maybe an idea that can hop along the system to help the rest of us do our work as well.
I'm happy to set up a meeting with you to show you. If you would like.
Yeah, that would actually be really,
It's like,
yeah.
yeah, we could do a little session together.
It's a little cross training. Yeah.
I love doing it. It's fun.
And we also, do you want to talk about the onboarding support that got expanded?
Yeah. We actually have a couple of initiatives that have gotten expanded. And I want to say two things actually, but one, we created for DPC, and there was, you know, the onboarding, there's just information from so many different places because there's training requirements from like DHR and then PhD and then the city. I mean, so it's coming from many different places. It's hard to track. And so what we learned when we had done a needs assessment from the supervisors community practice, managers didn't even know what the requirements were for onboarding to guide their staff through them. And now there is a group in PhD that's working on onboarding, which is wonderful. But prior to that, we had put together this required onboarding. We put together a little group and put together one resource that had a tool to take everyone through everything that was required on one sheet, all the links, we were updating it, et cetera. And now it's gotten handed off to this group. And we also put together this onboarding training manual, is that what you asked about? And so we made one for Lynx. It took a long time, almost a year. And then we made one for our team. And we ended up making a general template after we presented it at a conference a few months ago. We presented the process of it. And so now we have a general how to build a training template with examples. And so now it can be handed off as like a general template as a resource to how to build a training template. And then we sent it off to, I think, 8 jurisdictions across the country in public health that were asking for it after we presented. So we do take small things and then try to, like a startup, you know, kind of build them as big as, and then, you know, likewise with our simulations that we did, we've taken materials like how to do a simulation and shared that with other departments.
How incredibly useful.
But what I was going to say about, the other question, is the other thing about funding, sorry, I'm taking too long, but the other thing about funding and duration is with digital literacy and lots of our initiatives. And I was feeling for Bill when he was talking about trying to get data to show movement out of Epic, but a lot of we're a new team. I've been with Radar like almost the longest next to Joshua, and it takes time to like do these are long ongoing projects. So to show like retention outcomes and all these, we want to be able to measure the impact of what we're doing, but it takes time to really see it all the way through to say, we have a workforce, we're going to do these, and then are these things effective? And it takes time to put these into place, do a baseline, and then look at whether they're effective. And we need time, right? So we'd like some time to make sure that what we're doing works and then get it to maintain and sustain itself. So I think, anyway, sorry.
No, please don't apologize.
Yeah.
Well, I hope and trust that the city will get you the funding that you need to continue the work and to continue to share it. Anything else?
Commissioner, may I ask a
Yes.
follow-up question? So I'm a long-term city employee. I've worked on and off of the DPH for 30 years, and your work sounds amazing. What I've seen many times is that it's the people in the positions that matter. And so if the three of you go away, would the work that you are doing, like, it sounds like there are modules that you've created and things you've created, but like, is there also a strategy manual or like, this is how we do it, so that no matter who's sitting in your position, someone else can come and do it? Because that, to me, is the magic that sometimes is left up to the individual.
So as Julia mentioned, I think as is obvious, if we were to lose this team, there would be loss. Not all of the work we're doing would be lost because of initiatives like the onboarding template that Jen just spoke about and the lasting impact of digital literacy if you can maintain good retention rates. And in terms of, I think kind of what your question is about is succession planning for roles. And that's a huge gap that we've seen identified. So yeah, if we were gone today, maybe not. Maybe the work wouldn't continue and the modules would certainly not be maintained. One of the things that we're working with a contractor to do right now is to come up with really comprehensive who you are in your role documents for people on our team that hopefully will spread to other teams as well, that spell out not just what your job class code is and what the 8 bullet points of your job description are, but how to crosswalk your job descriptions bullet points into your activities of daily work, and also how to translate your needs into who you need to email, who you need to Teams with, and what existing documentation has been there. So that's kind of a little bit of a tip of the iceberg situation for us.
Thank you. And just as, again, somebody is an old timer, I wasn't even thinking about you all actually going away, but just literally anyone in any of our positions should always be thinking about, well, because I've been here forever, it's like I need to make sure that whoever comes in next doesn't have to start from scratch. So I encourage you all to do that work, not thinking about you not literally being here, but that it's helpful as part of this process to make sure their work will continue. And I think Deputy Baba.
Yeah, and I really do want to thank you all for your work. Along with Dr. Phillip, I think we've been through many emergencies where we see this kind of same recurrent thing with bioterrorism for a while and H1N1. And then just every time there's this cycle that is created around people getting all this work up and then it kind of goes away. And so I do really think, this will be the cycle. It's just the way it works at the federal and state level. Things are like immediate and then it goes away. But I think thinking through like, okay, what are the things that we can sustain? And the digital model is, I think, something fairly new. So I think that's very exciting. And I do look forward to the continued work there. So thank you.
Thank you so much.
All right. And please feel free to mosey on if you'd like to. Item 5 is emerging issues.
So this is a chance for us to talk about things that are emerging and that we see as issues. I said a little bit at the last meeting, and so I will not gonna pile on here. And Commissioner Salgado, as you continue to attend meetings and think about, I'm sure you have ideas about things that you would like to see happening in the city or information about things that we know are happening and updates or how it applies to something that I've read or you've read. And so this is really, we don't utilize this space enough, I think, but hopefully we will, myself included, begin to utilize it a little more. So
Thank you.
nothing for me.
All right. And Commissioner Salgado, just checking, nothing from you. Okay, great. All right, so we can move on to public comment. And I see staff in the room and there's nobody remotely who can provide public comment. So please consider a motion to adjourn.
I will consider a motion to adjourn.
I'll second.
Well, all those in favor?
Aye.
Aye.
All right, thank you so much. And again, congratulations on making it through your first meeting, Commissioner Salgado. Give me 30 seconds to stop us.